The next presentation will be, is it Dr. Georgiev? For clinical outcomes in direct and indirect recanalization of infrapopliteal arteries.
Good afternoon, everybody. Dr. Georgiev wasn't able to attend today, so I will be performing in his stead. I'm sorry for that. I'm Dr. Ivana Stefanova, and I will present the clinical outcomes in direct and indirect recanalization of infrapopliteal arteries. The study was conducted by the University Hospital in Medica Ruse and in collaboration with the Department of Vascular Surgery in the Military Medical Academy in Sofia. I will begin with a little statistic. The peripheral arterial disease affects more than 200 million people worldwide. Approximately 10 to 20% of the patients with peripheral arterial disease develop chronic lymphadenemic ischemia. Infrapopliteal lesions are present in more than 70% of the patients, and the yearly risk of major amputation is approximately 15 to 25%. The 5-year mortality rate may reach 50 to 60%. In patients with chronic lymphadenemic infrapopliteal lesions, represent of the greatest therapeutic changes in vascular surgery. The decision between direct and indirect revascularization may influence not only vessel patency, but also wound healing, limb salvage, and overall patient survival. So the main two strategies in revascularizations which are commonly discussed are direct revascularization based on the target artery concept and the indirect revascularization based on the angiosome concept. An angiosome is a three-dimensional anatomical block of tissue supplied by a specific source, artery. The concept describes the direct relationship between a particular artery and its corresponding cutaneous and muscular territory. In the presence of trophic lesions, the goal is to restore blood flow in the artery, directly supplying the affected angiosome. The approach is defined as direct revascularization when the artery restores the blood flow to the lesion. Then, when perfusion reaches the lesion through collateral circulation, it is referred to as indirect revascularization. The direct perfusion may provide improved tissue oxygenation, faster wound healing, and reduced of major amputation. Collateral circulation, however, is often insufficient in cases of diabetic, microangiopathy, multisegmental occlusions, and compromised distal runoff. So the study was conducted over a 1-year period. A cohort of 35 patients was evaluated. It included 32 men and 3 women, who were treated with endovascular therapy based on the angiosome concept. The mean age of the patients was 69 years, and it ranged from 44 to 85 years. Preoperative assessment was performed using duplex ultrasonography and digital subtraction angiography. The aim was to compare the clinical outcomes of direct and indirect infrapopliteal revascularization performed according to the angiosome concept in patients with trophic foot lesions. The study evaluated wound healing time, time to complete epithelialization, risk of major amputation, and the overall outcome of clinical study. Wound healing was defined as complete epithelialization of the primary ulcer with or without minor amputation. Whenever needed, the debridement was performed prior to the intervention. Poor wound healing was defined as lack of improvement within 4 weeks, wound progression, and need for major amputation. The patients were divided in 2 groups. The direct group consisted of 22 limbs. It had successful restoration of blood flow achieved by PTA. It was associated with lower risk amputation. Indirect revascularization consisted of 13 limbs. There was no direct perfusion to the affected angiosome, and it held a higher risk of amputation. The clinical assessment was performed according to Rutherford classification and wound localization. Comparison of demographic characteristics between the two groups showed no statistically significant differences. Risk factors such as cardiovascular disease, smoking, diabetes mellitus, and also showed no statistically significant differences. The angiographic findings were the main guide in selecting the target tibial vessels for the treatment. When initially revascularized artery did not provide direct perfusion to the wound, we attempted to revascularize a second tibial vessel whenever technically feasible. The approach aimed to improve foot perfusion, collateral circulation. All procedures included tibial artery angioplasty with or without proximal intervention. Balloon diameter was selected according to the angiographic findings. Patients were followed for a year after the intervention, and we evaluated the limb salvage, and the amputation-free survival, and the wound healing. The analysis demonstrated higher amputation-free survival in the direct revascularization group and overall better outcomes. Despite angiographic technical success, 6 limbs showed no significant hemodynamic improvement. Main causes included compromised distal runoff, persistent high-grade stenosis in remaining tibial vessels. The overall 1-year wound healing rate was 93%. Higher healing rates were observed in the direct revascularization group compared to the indirect group. The regression analysis did not demonstrate a statistically significant difference in time to wound healing between the groups. However, there was a trend toward faster healing in the direct revascularization group. The mean healing time in the direct group was 109 days, and compared to the indirect, 318 days. 5 patients experienced worsening of wound status, 2 in the direct group and 3 in the indirect group. Despite repeat interventions, major amputations were required in 3 patients. In cases of infection, systemic and local antibiotic therapy was administered, followed by standard wound care. In conclusion, the direct revascularization had better outcomes overall, but even temporary improvement in perfusion through collateral circulation was sufficient to achieve wound healing, especially in patients who had severe comorbidities and those who were unsuitable for bypass. Thank you all.
Thank you for that talk. Any questions from anyone? Just a quick question from me,
Yes.
if that's okay. How do you determine if someone's unsuitable for a bypass?
How do we determine? It depends on the patient, and if it has major calcinosis, the proximal and the distal arteries are unsuitable for for performing a bypass.
Well answered. Thank you very much.
Thank you.
So I think now is a coffee break.
Yes.
Yep. And then we'll be back 20 minutes, and then the live case with the melody graph.